Aging, childbirth, the profound hormonal shifts of perimenopause and menopause.
Right, the fundamental physical events that completely alter how a woman's body responds to intimacy.
Exactly. And we are looking at a reality today where 40 to 50% of women experience some form of sexual dysfunction.
Which is a staggering number.
It really is. We're talking about decreased sensitivity, severe vaginal dryness, pain during intimacy, and, a sheer inability to achieve orgasm.
Yeah.
Almost half of all women are walking around with these symptoms, yet it remains this silent epidemic. It's rarely discussed openly, which leaves you, the person actually experiencing it, to just quietly endure the discomfort.
And for decades, I mean, the mainstream medical toolkit offered to women dealing with this was incredibly limited.
Right, you'd go to a doctor, mention the discomfort, and generally just be handed a prescription for a topical hormone cream.
Or a recommendation for over-the-counter lubricants.
Yeah, or in severe structural cases, a referral for highly invasive surgery. There was very little middle ground for actual tissue regeneration.
Which is exactly why we're here. That gap in the medical landscape is the driving force behind our mission for this deep dive with you today.
We are asking a highly debated, very specific focus question. Can the O-Shot actually improve arousal?
To answer that, we have pulled together an incredibly diverse stack of sources for you. We are not just looking at one side of the argument here.
Oh, definitely not. We have everything from glossy, high-end cosmetic clinic brochures and step-by-step medical training manuals, all the way to rigorous systemic clinical reviews and hard surgical data.
Because our ultimate goal is to cut through the noise.
Right, separate the aggressive marketing hype from the actual biological reality. By the time we wrap this conversation up, you are going to understand the exact mechanism of this treatment, what the clinical data genuinely proves, and whether it represents a viable medical path for your own sexual wellness.
Or for someone you care about, yeah. So, to evaluate whether the O-Shot can legitimately improve arousal, we really have to start at the molecular level and unpack exactly what is being introduced into the body.
Yeah. This is a vital distinction because we're not dealing with a synthesized pharmaceutical drug created in a lab.
No, not at all. We are talking about platelet-rich plasma, or PRP.
Which, on the surface, sounds a bit like science fiction. I mean, you walk into an office, and within 20 to 30 minutes, the entire procedure is done.
It's fast.
So walk us through the physical mechanics of how a clinic actually extracts this from a patient.
Sure, so the procedure begins with a standard blood draw. The clinician will take somewhere between 10 to 60 milliliters of blood from your arm.
So very much like a routine cholesterol check.
Exactly like that. And that vial of blood is immediately transferred into a centrifuge.
Now, the medical training manuals in our sources are heavily fixated on this next step. It's not just a matter of tossing the blood in and turning it on.
Right. It's very precise.
The guidelines dictate centrifuging the sample at exactly 3,200 revolutions per minute for 8 minutes. What is happening inside that machine at that specific speed?
Well, the centrifuge is utilizing intense gravitational force to separate the components of your blood strictly by their physical density.
Okay.
So the heavy red blood cells sink to the absolute bottom of the tube. The watery yellowish plasma rises to the top. But sandwiched right between those two layers, the spinning creates a very thin, highly concentrated middle band.
The buffy coat.
Yes, in medicine, they call it the buffy coat. And that specific layer is your platelet-rich plasma. It contains a massive concentration of the body's natural healing cells.
I noticed the clinics often refer to this buffy coat as liquid gold because of all the growth factors inside.
I love that term, yeah.
But from my reading of the procedure, a clinician doesn't just draw that layer up into a syringe and inject it immediately. There is an activation step.
Right, because if you just injected dormant platelets, the body wouldn't do much with them.
They're asleep.
Basically, yeah. Platelets naturally circulate in your bloodstream in a sleep state. They're waiting for a traumatic signal like a cut or a broken blood vessel to wake up and start the healing process.
But the clinician isn't creating a massive wound during the O-Shot.
Exactly. So they have to chemically trick the platelets into thinking an injury has occurred. They do this by adding a small amount of calcium chloride to the PRP syringe.
How does calcium chloride trick the cells exactly?
So calcium is the essential mineral that biological enzymes require to trigger what is called the thrombin cascade.
Which is a biochemical chain reaction,
Yeah,
right?
a very rapid one, yes. The introduction of calcium chloride artificially spikes the thrombin levels, which causes the platelets to degranulate.
Meaning they burst open?
They literally burst open inside the syringe, dumping their payload of specialized proteins. And two of the most critical proteins released are vascular endothelial growth factor, or VEGF.
And platelet-derived growth factor, or PDGF.
You got it.
Let's define what those specific proteins actually do once they're unleashed in the body.
Well, VEGF is basically the biological architect for new blood vessels. When it floods a tissue, it commands the surrounding cells to initiate angiogenesis.
Meaning laying down entirely new capillaries and increasing blood flow to the area.
Exactly. And PDGF works right alongside it, recruiting specialized cells called fibroblasts to flood the area and synthesize brand new collagen.
Which provides structural thickness and elasticity to aging or thinning tissue.
Right. So with the PRP fully activated and those growth factors bursting, we reach the injection phase.
The manuals note that a heavy-duty topical numbing cream, specific blend of lidocaine and prelocaine, is applied for 20 minutes.
Which is crucial, yes.
Then the clinician uses a tiny 27 or 31 gauge needle to deliver the PRP, and that is roughly the microscopic thickness of an insulin needle.
It's extremely thin.
But the clitoris and the anterior vaginal wall are incredibly complex, nerve-dense areas. How do clinicians ensure they're actually hitting the right neurovascular pathways and not just blindly injecting fluid?
That's where the technique comes in. Clinicians are trained to use a highly structured protocol, often referred to as the clock face method.
Like a literal clock.
Exactly. When injecting the clitoral complex, they don't just aim for the center. They methodically place micro-injections at the 12, 3, 6, and 9 o'clock positions around the structure.
Oh, wow.
Yeah, and they also inject into the anterior vaginal wall. They're specifically targeting the submucosal layer near the urethra, which is a tissue generally associated with the G-spot.
So they are deliberately blanketing the entire neurovascular network of the pelvic floor with these released growth factors.
That's the goal.
So if traditional treatments like topical estrogen creams or daily moisturizers are essentially like, constantly changing the light bulbs in an old house when they flicker.
Just treating the end-stage symptom.
Right. The O-Shot is more like going deep into the walls, tearing out the frayed cables, and laying down entirely new copper wiring and a brand new breaker box. You are rebuilding the fundamental electrical grid of the tissue.
I'll actually take that structural analogy a step further.
Yeah.
You aren't just laying down new copper wiring. The VEGF and PDGF are stimulating the house to autonomously grow its own new wiring.
That's wild.
It is. Because beyond just blood vessels and collagen, these growth factors support neurogenesis.
Right.
They have the capacity to physically repair and grow the microscopic sensory nerve endings that degrade over time.
Which are absolutely critical for a woman to detect touch and experience physical pleasure.
Exactly.
So the biological mechanism makes perfect logical sense on paper. You introduce growth factors, you get new blood vessels and nerves. But, theory often falls apart in practice.
It does.
How does this biological rewiring translate when it's actually tested on postmenopausal women who are experiencing severe clinical dysfunction?
The clinical data provides a highly compelling answer to that. We can look at a landmark study published in the journal Frontiers.
Right, the one with 66 postmenopausal women.
Yes. They were all suffering from vulvovaginal atrophy, meaning their tissue had thinned, dried out, and become painful due to a lack of estrogen. Half of the women were given standard topical estrogen creams, which is the traditional medical gold standard.
And the other half?
The other half, specifically those who had failed to see results from estrogen in the past, received the PRP injections.
And to measure the results of something as subjective as arousal, they used the Female Sexual Function Index, the FSFI, along with the Vulvovaginal Symptoms Questionnaire.
Right, and by the 12th week of the clinical trial, the women who received the PRP injections demonstrated a statistically significant improvement over the estrogen group.
Meaning their overall sexual function scores rose dramatically.
And their daily vulvovaginal symptoms plummeted. The objective health of their pelvic tissue was visibly restored, and their functional response to intimacy followed suit.
The data point that completely arrested my attention came from the Sujin study in our stack.
Oh yeah, that one is striking.
The researchers tracked women dealing with severe sexual dysfunction, and they recorded their baseline FSFI scores. The maximum healthy score on this index is 36. Anything below 26 is considered clinical dysfunction.
Right.
The average starting score for the women in the study was 13.61.
A score of 13.61 represents a profound emotional and physical burden. At that level, a woman is likely experiencing significant physical pain during any intimate contact, a total absence of natural lubrication,
A complete lack of spontaneous desire.
and an inability to climax, It impacts your self-esteem, your relationship, and just your daily comfort.
But post-treatment with the PRP protocol, that incredibly low average score of 13.61 skyrocketed to 27.88.
They physically cross the medical threshold from severe clinical dysfunction back into the normal, healthy range of sexual function.
And the researchers specifically highlighted that the most massive statistical improvements occurred in the orgasm subdomain of the questionnaire.
Because moving from a 13 to almost a 28 is not just a marginal bump in a medical chart. It represents a woman regaining an entirely functional, pain-free, intimate life.
Okay, but let me challenge the mechanics of this, though. When you have results that dramatic, how do we rule out an incredibly powerful, incredibly expensive placebo effect?
That's a very fair question.
I mean, if a woman goes to a high-end wellness clinic, pays thousands of dollars out of pocket for a premium, cutting-edge procedure involving needles and centrifuges, isn't her brain naturally going to be hyper-attentive to her body?
Absolutely.
Could these women just be feeling better because they're finally taking aggressive, proactive action regarding their sexual health?
Skepticism is a vital part of analyzing these treatments.
Hmm.
To address the placebo question, we have to look at the DialNet systematic review.
That's the one that analyzed 17 independent studies on PRP for female sexual health, right?
Yes. And the researchers concluded that while a placebo effect might boost a subjective mood or desire questionnaire, the physical tissue changes they recorded cannot be manifested by the mind alone.
You can't just think yourself into more collagen.
Right. The review documented a 20 to 60% increase in objective, measurable lubrication production and a 25 to 70% improvement in physiological orgasm capability. The body is demonstrably changing.
But even with those objective changes, the systematic review throws a massive red flag regarding how the treatment is administered across different clinics.
Yeah, the DialNet review points out that the current data is wildly heterogeneous. The protocol is just all over the map.
You have clinics drawing 2 milliliters of blood while others draw 10.
Some clinics centrifuge the blood once, others insist on a double spin technique, some use the calcium chloride activator, others skip it entirely.
So while the core science demonstrates efficacy, the universal optimal medical protocol is still classified as investigational.
Exactly. And that lack of standardization creates a bit of a Wild West scenario for the consumer.
With highly promising clinical results but no unified protocol, cosmetic and wellness clinics have aggressively entered the space. Let's examine the commercial landscape in our sources.
It's intense.
You look at marketing materials from Nor Women's Health, Fox Valley Plastic Surgery, or the Center for Cosmetic Surgery. They are promising that a single O-Shot can treat stress urinary incontinence, which is the involuntary leaking that happens when you laugh or sneeze.
Right.
They promise a return of natural lubrication, tighter vaginal skin, and stronger orgasms that will last anywhere from 14 to 18 months. And the financial barrier to entry is steep.
Very steep.
A single shot averages between $1,200 to $1,800, with comprehensive treatment packages running up to $2,500.
And when a patient is making that level of financial investment, managing expectations becomes critical.
Which is where the Women's Health Clinic guidelines and our sources provide a very necessary, grounded reality check against the marketing gloss.
Yes, they explicitly warn clinicians that the O-Shot absolutely cannot promise a woman her first orgasm.
Why does a purely biological treatment fail to guarantee a biological climax?
Because anorgasmia, the inability to achieve orgasm, is not strictly a hardware problem. It is profoundly multifactorial.
So it's not just about blood flow.
Right. Achieving climax obviously requires healthy vascular and nerve tissue, but it equally requires emotional safety, mental presence, and a relaxed pelvic floor. A woman could have the most beautifully vascularized, nerve-dense tissue on the planet thanks to the O-Shot. But if her pelvic floor muscles are locked in a state of chronic spasm due to anxiety, or if she is navigating deep relationship trauma, a shot of localized growth factors will not magically bypass those hurdles.
It is a regenerative tool for the physical tissue, not a psychological magic wand.
Exactly.
Well, the fact that these growth factors are so biologically potent leads directly to the question of what happens when the biology works a little too well.
The side effect profile.
Yeah, the side effect profile in our data is fascinating. The Nova Voya dataset analyzed 317 women across 12 different clinical studies. Out of hundreds of procedures, only 3 women reported any side effects whatsoever.
Which is wild. A side effect rate of less than 1% is almost unheard of in medicine.
Why is it so low?
It largely comes down to the autologous nature of the treatment. Because the clinician is injecting your own biological material back into your body, the risk of rejection, allergic reaction, or foreign body response is virtually eliminated.
The side effects those three women experienced, however, were intense. Two of the women developed continuous spontaneous arousal.
Yes.
Their newly regenerated nerve endings became hypersensitized, and their bodies basically went into an unprompted physiological overdrive.
Which sounds incredibly uncomfortable.
It entirely resolved on its own after a week or two, but it proves just how fiercely these nerves can react to the VEGF and PDGF proteins.
And alongside the physical reactions, the Women's Health Clinic guidelines warn clinicians to screen for a deeply psychological risk called paradoxical distress.
Paradoxical distress. Explain how a successful medical treatment creates distress.
So, picture a couple where the woman has suffered from a severely low libido for a decade due to hormonal changes. The dynamic of their intimacy has settled into a specific, quiet routine.
Okay.
She receives the O-Shot, her tissue successfully regenerates, her physical sensation roars back, and suddenly her sex drive is completely reinvigorated.
Sounds like a success.
It does. But however, her partner's libido has remained exactly where it was. The treatment achieved its exact medical goal, but it inadvertently created a glaring relational mismatch.
Wow. So her newly restored desire outpaces her partner's interest for physical capacity, introducing severe friction into the household.
Right. It's a stark reminder that sexual medicine operates inside a complex human ecosystem.
If the O-Shot carries that $1,800 price tag, requires navigating relationship dynamics, and isn't a guaranteed fix, how does it compare to the other medical interventions available for sexual dysfunction?
Well, the broader medical toolkit offers a few distinct pathways. The sources point to transvaginal laser therapy as a primary non-surgical alternative.
Like the Mona Lisa touch.
Yes. According to a clinical overview by NICE, the National Institute for Health and Care Excellence, treatments like the Mona Lisa touch show significant improvements in arousal and lubrication scores at 14 weeks when compared to traditional estrogen creams.
But how does a laser rebuild tissue without using the blood's growth factors?
Lasers operate on the principle of controlled damage. The device emits precise light energy to create microscopic thermal traumas along the vaginal wall.
So it's basically burning the tissue.
Microburns, yeah. The body detects these hundreds of tiny burns and rushes its own natural healing response, including collagen production and increased blood flow to the area to repair the damage, which inadvertently rejuvenates the entire tissue structure.
For other women, though, the barrier to arousal isn't about blood flow or collagen at all. It's entirely structural. The Gyne Doctor's source details the surgical route, specifically a procedure called a clitoral hoodectomy.
Right, because some women possess excess mucosal tissue that physically drapes over the clitoris, acting as a thick barrier that blocks direct physical stimulation.
And a hoodectomy is a surgical excision of that excess skin, permanently uncovering the nerve center to allow for greater physical access and reduced painful friction. But a hoodectomy requires actual surgery. Let's look at the data from the Ambulatory Surgery Journal regarding elective day surgeries. We culturally view outpatient day surgery where you go home the same afternoon as essentially risk-free.
We do.
But the journal tracked readmission rates, and patients do end up back in the hospital after these procedures.
Yeah, the study found an unexpected hospital readmission rate hovering around 9% for day surgeries.
9%.
Right. And what drove those readmissions wasn't necessarily a failure of the surgical technique itself, but rather the underlying patient factors.
Like what?
The highest risks for readmission were advanced age, specifically patients over 75, and patients possessing a high ASA grade, which is the anesthesia scoring system that measures your overall systemic health and presence of severe diseases.
I found a fascinating detail buried in that data. We often assume that higher weight automatically correlates with higher surgical complications.
People usually assume that, yes.
Yet the study definitively found that obesity, having a BMI over 30, was entirely a non-factor for hospital readmission in these outpatient procedures. Why wouldn't obesity cause complications?
In the context of elective day surgery, anesthesiologists are intensely focused on the systemic function of the organs. A patient with a BMI of 35 who has healthy lungs, a strong heart, and no diabetes, giving them a very low ASA grade, will handle the minor stress of an outpatient procedure just as well as someone with a lower BMI.
So the readmissions are driven by the complex internal failures of systemic diseases, not the purely physical metric of body weight.
Precisely.
Well, this surgical data perfectly illustrates why the O-Shot has captured such a massive segment of the sexual wellness market.
It really does. Procedures like a hoodectomy or a labiaplasty expose the patient to the inherent risks of general or localized anesthesia, the threat of postoperative infection, the possibility of surgical nerve damage, and a painful, prolonged recovery window.
Whereas the O-Shot utilizes autologous material and is administered as a simple in-office injection.
Right, it entirely bypasses the readmission risks and surgical complications detailed in the ambulatory surgery journal. There is zero surgical downtime.
The only requirement is a brief 24 to 48-hour pause on sexual activity to allow the growth factors to settle into the tissue.
That's it.
So we've mapped the cellular biology, scrutinized the clinical trials, broken down the exorbitant clinic pricing, and weighed the alternatives. For you, the listener, trying to determine if this procedure is legitimate, what is the ultimate conclusion? Can the O-Shot actually improve arousal?
Synthesizing the clinical data, the systemic reviews, and the biological mechanisms, the answer is a heavily qualified yes.
Yes, the O-Shot possesses the biological capability to improve arousal and lower the threshold for achieving orgasm. The fundamental mechanism is sound. It utilizes your body's own localized growth factors to physically regenerate degraded nerve endings, synthesize thick new collagen, and build new capillary networks for engorgement.
And the clinical trials confirm significant, measurable improvements in natural lubrication and functional satisfaction for a majority of the women tested.
But the qualifications are what separate the medicine from the marketing.
Yes, the regenerative biology demands patience. It takes up to 3 full months for the new blood vessels and nerves to fully form and integrate.
It frequently requires a series of expensive injections rather than a single visit.
And most critically, it is a targeted treatment for the physical hardware of the pelvic floor. It functions best when integrated into a holistic approach to sexual wellness, rather than being deployed as an isolated miracle cure to resolve complex relational dynamics.
Rebuilding the physical hardware of the body is a massive medical achievement, but it forces us to step back and look at the broader picture of human intimacy.
It really demands that we ask a profound question about the nature of human desire. I mean, if medical science has advanced to the point where a machine can spin our blood and extract the exact molecular building blocks to rebuild the physical structures of arousal, how much of sexual dysfunction is purely physical versus psychological? We run the risk of hypermedicalizing female pleasure, hyper-focusing on repairing the pelvic tissue with needles and lasers, while entirely forgetting that the human brain processing emotions, stress, safety, and connection is ultimately the most powerful sex organ of all.
That is definitely something to think about. Thank you for joining us on this deep dive. Keep questioning the science, keep demanding better answers for your own health, and we will catch you next time.